Hello, I am Keith Lim from Kuala Lumpur, Malaysia. I practice as a rheumatologist. Rheumatic diseases form a major part of consultations in primary care and hospital practice. It is important, therefore, that practicing clinicians are familiar with and competent in the basics of musculoskeletal examination. We would like to introduce you to a simple teaching aid in musculoskeletal examination technique. We call it the GALS screen. The original GALS screen was jointly developed by Professor Michael Doherty of Nottingham University and Professor Paul Dieppe of Bristol University 10 years ago. This version has been developed specifically for the Asia-Pacific region. Musculoskeletal disorders form a major part of the region's health concerns. The health challenges faced by emerging Asia-Pacific nations must be met by a strong foundation of musculoskeletal medicine and teaching. We hope that you will find this teaching aid instructive and applicable in your practice.
The title GALS is derived from gait, arms, legs, spine, and describes the area for examination. The locomotive system is complex, and an extensive history and examination can be time-consuming. GALS locomotive screening takes only a minute or two to perform and can be easily incorporated into the patient's examination. A convenient way of recording findings in the notes is the GALS template, using the letters GALS with additional A for appearance and M for movement. A tick is given for normal and a cross for abnormal. If abnormalities are detected, they can be described further underneath. First, let's look at the GALS assessment in real time carried out by Professor Paul Dieppe.
Hello, I'm Paul Dieppe and I'm going to demonstrate the GALS system for you on a normal patient first. William, thank you very much for coming. 3 quick questions first, if I may. Do you have any pain or stiffness in your muscles, your joints or your back?
Oh, no.
Okay. And can you wash and dress yourself completely without difficulty?
Yes.
Good. And what about getting up and down stairs and steps? Is that easy?
Yes, yes, no problem.
Okay, thank you very much. Now, what I'd like you to do is stand yourself up, if you would, so I can see you walking. So if you could stand up for me.
Okay.
And perhaps I could just see you walking up and down here, so I can watch how you walk. All right, that's good. Okay, and turn yourself round for me, and walk back towards me here, William. Okay, that's good, thank you. And what I'd like you to do next is undress yourself so I can examine you a bit more closely, if I may. Thank you. Okay, William, are you ready?
Yeah.
Okay, out you come. Okay, thank you very much. I want to look at your spine first, William, if I may. Could you turn round so that I can see your back and have a look at your back? All right, that's good. And now turn around a little bit that way so I can see from the side. And just take that for me there. All right, I'm just going to put my fingers on your spine now, and I want you to bend down and touch your toes for me, if you would. That's very good. And up you come again. All right. That's fine, thank you. William, I'd like to look at your hands and arms next. Could you just hold your hands out for me like that so I can look at them? Thank you. And I'm just going to squeeze across here. Does that hurt you at all?
No.
And can I try that one?
Yes.
Not painful?
No.
All right. Could you turn them over? Right over like that. That's very good. All right. And now make a fist for me, tight together, and spread right out again. Good. And now can we pinch like that? Very good. Okay. And now I want you to spread your elbows right out straight. Very good. And next I want to see if you can get your hands behind your head and then put the elbows right back. Excellent. Okay. And drop down. Thank you very much. That's fine. William, I want to see your neck movement now. Can you just try and get your head over to the side there as far as it'll go? All right. And now the other side, the other way. Okay, that's grand. Good. And I just want to see if you're tender in the muscles around the neck here. Now, does that hurt you at all?
No.
And can I just try this side here?
Yeah.
No pain when I do that?
No pain.
Okay. Thank you, William. what we need to do next is have a look at your legs and have a look at your feet so that we can see what the hips and knees are like. All right? I just want to start by just having a look at your legs here, if I may. That's grand. All right. Now, I wonder if we could bend this leg up here. Bend it right up. And I just want to give it a twist there. Does that hurt you at all? That's all right? Okay. And let's just try the other one. Bend this one right up there. And give it a twist around that way. No trouble with that? All right. Good. Let's do the knees next. I'm just going to look at those and then feel across here, if I may. All right. And this one. Okay, that's grand. And now let's have a look at your feet. All right, William, and I'm just going to squeeze across your toes here. Does that hurt you at all? And can I try this side? No pain when I do that. All right, William, I think we're done. Thank you very much. We're now going to go through each element of the GALS screening system more slowly and explain how they pick up musculoskeletal disease. First, let's talk about the 3 simple questions that we asked William. First, whether he had any pain or stiffness in his muscles, his joints, or his spine. Pain and stiffness are the 2 cardinal symptoms of rheumatic diseases. If you don't have any pain or stiffness in any of the joints or the spine, it's unlikely that you've got significant disease. The other 2 questions related to the commonest forms of functional problem that come from musculoskeletal disorders. They are reaching and movements of the upper limbs, and they often compromise things like dressing and washing. So I asked him whether he had any difficulty with normal dressing and washing. Secondly, problems of the lower limbs that give you difficulty with locomotion, and the principal things that affects first are ability to get up and down steps and stairs. If you can do that normally, it's unlikely you've got a problem with your lower limbs. So 3 simple questions that pick up the major symptoms and functional problems of musculoskeletal disorders. The first part of the examination was the patient's gait and transfers. Now what we're looking for here is the ability to easily transfer from chair, sitting position, or from the lying position to standing up and walking. And then when it comes to the gait itself, we're looking for symmetrical pattern of walking, easy flowing swing of the arms and legs, ability to turn round quickly and easily, and to do all this without any evidence of pain that might come from the facial expression.
Now look at a patient with an abnormal gait.
The point of the GALS system is that we're looking at things of most importance to the patients themselves. Now clearly with the musculoskeletal system, ability to transfer, that is getting on and off chairs, on and off the bed, and ability to walk easily, locomotion, are amongst the most important functional things. What we're going to do next is look at a patient who has difficulty with transfers and difficulty with walking. In Nathan's case, what you can see is that he has difficulty getting out of the chair and has to use the arms and the shoulders to help lever himself up to the standing position. Then when he walks, he's noticeably slower than William was, and he has a tilt to the side because he's got a painful hip. His facial expression shows that as well. It's obviously uncomfortable to walk. His gait is what's called an antalgic gait, with the gross asymmetry due to a bad hip on one side.
To summarize then, when we examine the gait, we look for smoothness and symmetry of leg, pelvis and arm movements, normal stride length, and ability to turn quickly.
GALS stands for gait, arms, legs and spine. But in practice when we do the examination, it's usually simpler to go from the gait to the spine next. And that's what we did here in William's case. Now when we come to the spine, I first look directly at it from the back, and I'm looking particularly there for any abnormal scoliosis, curvature of the spine, and also for the symmetry of the paraspinal muscles and for symmetrical pelvic position. I then asked him to turn so that I could see the spine from the side. This is the best way to look for the normal curvatures that occur at the neck, in the thoracic spine, and the normal lumbar lordosis. Finally, we look at movement. Now, the best way to detect abnormalities of lumbar spinal movement is to put your fingers on the spines of 2 vertebrae and then ask the patient to bend forwards. If there's normal movement, the fingers move wide apart as the patient bends forwards and then move back again as they straighten up. And that's what you saw in William's case. Suresh is a young man who has ankylosing spondylitis, which of course is a disease that principally affects young males. Now, the striking features of early ankylosing spondylitis on examination are, first of all, the loss of the normal lumbar lordosis. And you can see that most markedly in Suresh's case. There is no lumbar lordosis, the whole lumbar spine is completely flat, and that's very abnormal in a young man. Secondly, when we did come to put our fingers on the two contiguous spines and ask him to bend forwards, there was actually very little movement of my fingers. So they don't move apart much as he bends forward and comes back again. And that's because there is great stiffness between the components of the spine, and most of his flexion is actually coming from the hip and not from the lumbar spine at all.
So when we're checking the spine, what we're looking for is from behind: straight spine, level iliac crests, normal and symmetrical muscle bulk, particularly paraspinal and girdle muscles. From the side, spinal curvature, scoliosis, lumbar spine, and hip flexion. From the front, lateral cervical flexion, hypoalgesic response of fibromyalgia.
The third element of the examination we did was to look at the upper limbs, the hands, the arms. Now, I started with the hands. The hands in rheumatology are often called the patient's calling card because you can see so much just from inspection of the hands, and because they illustrate so many of the rheumatic diseases in abnormalities that you can see. I started by looking at the back of William's hands. I'm looking there for abnormalities such as deformities of the finger joints, loss of muscle bulk, and a number of other physical signs that may show up with swellings and other abnormalities. I then asked him to turn his hands over. Now, the supination movement is a complex movement that comes from the wrists and from the elbows. If you can turn the hands right over quite smoothly with no evidence from the facial expression of any pain, then these joints are probably normal. That allows us then to inspect the palmar surface, where you can see a number of different abnormalities, such as redness over the palms, a common feature in inflammatory arthritis, as well as other swellings and deformities. I also squeezed across his metacarpophalangeal joints. Now, I did that because in early arthritis you'll commonly get pain and tenderness on squeezing before you can see any abnormalities such as swelling. So this is another part of the screen to detect early metacarpophalangeal joint disease, a common feature in early arthritis. Finally, we came to the functional part of the hand examination. Now, you need to be able to do two things with your hand. You need to be able to grip in a powerful way, and you need pinch grip. So I first asked William to make a fist, and I could detect then whether he had a good power grip. I then asked him to straighten his fingers right out again, and asked him to pinch between the first finger and the thumb, an important movement for things such as putting a key in a lock and turning the key. In William's case, both the power grip and the pinch grip seemed entirely normal. After the hands and wrists, I looked at elbows and shoulders. Elbow disease leads to early loss of flexion. So as a screening test for the elbows, just asking the patient to straighten the elbows out completely on both sides and looking at the symmetry of the movement and the ability to fully straighten the elbows is a very good screening test. In William's case, we can see that he straightens them out fully. He doesn't wince while he's doing that, so it's not painful, and they're totally symmetrical with full extension. Now, to test the shoulders, I then asked William to put the hands up behind the back of his head. This is a very complex movement. It involves elbow flexion, obviously, and also flexion and external rotation of the shoulder. I asked him to then put the elbows right back. This is to test the full degree of external rotation of the shoulder. Because again, what we're looking for is the movement that goes first if there's disease. And in the case of the shoulder, because of the anatomy of the joint, if you have disease there, external rotation is lost. In this one complex movement, we can see whether there's any asymmetry between the two shoulders, and we get the whole range of movement that's important. Functionally, it's an important test too, because if you can get your hands to the back of your head, you can also clearly get them to your mouth and to your perineum, which we need for normal functions of daily life.
Now let's look at some abnormalities of the arms and hands.
Nathan has rheumatoid arthritis, and you can see some of the typical abnormalities of his hands. When we first look at the hands, palm down, we can see that he has some ulnar deviation and some subluxation of some of the metacarpophalangeal joints, in addition to fixed flexion deformities of some of the interphalangeal joints. When I ask him then to turn the hands over, he's unable to fully supinate. This is because of problems at the wrists and elbows, which make it difficult for him to turn the hands right over. When we do see the palms, you'll notice there's some palmar erythema, which is a typical finding when there's active inflammation of the joints in the hands and consequent increased blood flow. However, when we come to the point of asking him to make a fist or a pinch grip, he can actually do those reasonably well. So there's fairly good maintenance of function in spite of the arthritis affecting the joints. We're now going to examine the upper limbs, arms of Carol, who has rheumatoid arthritis and has very kindly come along so that we can run through the GALS examination. Carol has quite severe rheumatoid arthritis affecting the hands and arms. We look at her hands first, and you can see there are quite striking deformities. The most obvious of these is first of all the swelling over the dorsum of the right wrist. Swellings of this sort can come from synovial protrusions from the wrist joint itself, or they can come from the extensor tendon sheath due to tendinitis. The other very obvious deformity of the fingers is the so-called swan neck deformity. This is due to hyperextension of the proximal interphalangeal joint and fixed flexion of the distal interphalangeal joint. Such deformities occur because in rheumatoid arthritis there's damage to the ligaments and flexor tendon sheaths as well as to the joints themselves, allowing the fingers to dislocate through the sheaths and lose the normal stability. She also has abnormalities of the metacarpophalangeal joint. When you look at the hand, that's not so obvious because there aren't gross deformities there and there don't appear to be swellings of the joint. But when I squeezed across them, she winced. So she's obviously got inflammation and trouble there. And it's a good illustration of the need to do the squeeze test of the metacarpophalangeal joints as well as examining the hand. Now the combination of abnormalities that Carol has got leads to quite severe functional impairment of her hands, and we can see that when we test her power grip and her pinch grip. First of all, with a power grip you can see that because of the deformity of the interphalangeal joints, she cannot fully flex the fingers, so she won't be able to get a good grip on the handle of, say, a knife or a fork. Finally, with the pinch grip there's abnormalities there too, because there's hyperextension of the interphalangeal joint of the thumb. So the thumb isn't providing the normal firm grip for the forefinger so that she can get a good ability to hold on to things. So trouble with both types of grip of the hand due to the advanced rheumatoid arthritis. Moving on to the elbows and shoulders, we then ask Carol to straighten her elbows right out. You can see that she can hardly straighten them at all. She's got very severe fixed flexion deformities of the elbow. Some 70 or 80 degrees of fixed flexion both sides. The final thing was to see whether Carol could get her hands behind her head and then whether she could get into external rotation of the shoulder. She can actually get her hands to the back of her head, and that's encouraging from the functional point of view because that means she's not going to have difficulty for the time being, in spite of the bad deformities, with feeding or washing or cleaning herself. She can get her hands to where she needs them. But nevertheless, we can see there is also shoulder difficulty because she can hardly get the elbows back at all. So there's quite severe restriction of external rotation of the glenohumeral joint.
Inspection of the arms standing from the front, normal girdle muscle bulk and symmetry. Sitting, normal acromioclavicular and sternoclavicular joints and glenohumeral joints and full elbow extension. On the hands, look for no swelling deformity, normal supination and pronation, normal palms, normal power grip and fine precision pinch grip, and no tenderness of the metacarpophalangeal joints.
William, I want to see your neck movement now. Can you just try and get your head over to the side there as far as it'll go? All right, and now the other side, the other way. Okay, that's grand. The other thing I did when looking at William's neck was to squeeze over the midpoint of the supraspinatus muscle. Now what I was looking for here was any tenderness. So while applying pressure, I was looking at his face. I'm trying to detect hyperalgesia or tenderness over this point because this is one of the commonest points to be very tender in the fibromyalgia syndrome. If I had detected tenderness on this point, I'd have gone on to look at the other characteristic points that produce hyperalgesia when people have got fibromyalgia. So what I'm doing here is feeling the midpoint of the supraspinatus and finding that she's really quite tender. So I could look to another common site here just below the medial epicondyle and squeeze there, and she really doesn't like that at all. Now that's another common site of the fibromyalgia syndrome, and there indeed are some 11 or 12 other characteristic spots around the body that might be tender in Rosalind's case with her fibromyalgia. The final phase of the examination was the legs. For this I needed William up on the couch so that he could spread his legs out fully in a relaxed fashion. I start just by looking at them. I'm looking again for any asymmetry between the two legs. I'm looking for normal muscle bulk, particularly in the quadriceps area, and I'm looking for any deformity or abnormality such as swelling over any of the part of the legs. I then screened for hip disease. Now, just as external rotation is the first movement to go with the shoulder, it's internal rotation that's first effective when you've got hip disease. Now, the way to test for internal rotation is to bend the knee up to full flexion, flex the hip to 90 degrees, and then rotate, as shown here in William's case, watching the face for any expression of pain that might come with internal rotation. We can see the extent of internal rotation on both hips and watch for any pain as well as any restriction. If there's no pain on internal rotation and that movement appears normal, then it's extremely unlikely that there's any hip disease present. When I was screening William's hips, I was also doing part of the knee screen, because as I bent the knee up and rotated the hip, my hand was over the knee joint, feeling for any crepitus on the flexion of the knee. Then, having let his legs down onto the couch, I can look more closely at the knee joint itself, first looking carefully at the bulk of the quadriceps muscle on each side, and then looking at the normal concavities which occur each side of the patella. If there's any effusion in the knee joint, you usually lose these concavities due to the swelling of either synovium or fluid making a bulge in the knee joint. Then the final part of my screening test was quite simply to run the back of my hand across the joint line. The back of your hand is very sensitive to any temperature change. So what I'm feeling for there is whether there's heat over the knee joint, which occurs if there's any inflammation or synovitis of that joint. Finally, the feet. Obviously, the first thing again is simply to look. We're looking here for any deformity or abnormality of hindfoot or forefoot. Next, as you can see, I have a careful look at the soles of the feet. The point here is that if you do have abnormal feet, or indeed any abnormal gait, it's likely to change the pressure points on the foot, and that leads to thickening of the skin or the formation of calluses either over the forefoot or the hindfoot. And calluses are a good sign that there's some abnormality of weight bearing. The only other thing I do for screening of the feet is to squeeze across the metatarsophalangeal joints. This is the equivalent of the squeeze we did at the hand joint, and the point is exactly the same. Early disease of metatarsophalangeal joints, which are commonly affected in arthritis, may lead to a lot of tenderness on lateral pressure before there's any signs such as swelling or deformity to be seen by inspection. So I squeeze across the joints, watching the patient's face for any expression to indicate that they're painful. The next patient who's kindly come along, Madame Tan, tells me that she's had trouble with pain getting up and down stairs, which was part of our screening questions. So I'm going to do the GALS screening examination of the legs to try and see why she's got this problem with steps and stairs. Madam Tan, thank you for coming. I just want to look at your legs first, if I may. And I noticed that compared with normal, there's some wasting of her quadriceps muscles here, which makes me think she might have a knee problem. Madam Tan, I'm just going to put my hand on your knee and I want to bend it up now, if I may. Can we bend up? And I can feel terrible crepitus of the knees there now. I'm just going to give a little twist, internal rotation of the hip. That's not worrying her. But as I straighten the knee out again, I'm watching her face and I can see the wince there. It's obviously quite painful bending the knees up, but a lot of creaking and crepitus over the knee joint as we put it down there. Right, looking more closely at the knee, I can see there's some wasting of the quadriceps muscle here. And there's a little bit of infilling of the normal concavity to the side of the patella, suggesting a small effusion. I'm going to run my hand across to see if it's warm. It's not particularly hot, normal temperature over the knee. A little bit of infilling there, suggesting a small effusion, but not much. So this is a lady with crepitus of the knee, wasting of the quadriceps, a small effusion, typical of osteoarthritis of the knee joint.
Summarizing then, inspection of the legs, standing and from the front, no knee, forefooting or mid-foot abnormalities. Lying on the couch, normal hip to knee flexion, no crepitus, normal internal rotation of the femoral head, no swelling of the knee, no callosities on the soles of the feet, no tenderness of metatarsophalangeal joints. The GALS locomotive screen is a simple and practical method for improving the recognition of locomotive disability and abnormality. The principal focus of the GALS method is on symptoms and activities which have a direct relevance to the patient. GALS takes only a minute to perform, making it easy to include in the patient's examination.